Good afternoon, friends. My name is Rajesh Gupta from Asian Institute of Gastroenterology. Welcome to the scientific program, our scientific webinar on care for colon, day 2. Today we have three important topics on endoscopic management of colon cancer. We have three eminent speakers who will speak on these three important topics. The first topic is early detection of colorectal cancer and neoplasia. The second topic will be the management of endoscopic management of colon cancer, early colon cancer, and lastly we will discuss the role of endoscopy, especially colonic stents, in management of colonic cancers. During these topics, we will discuss the diagnostic part, then therapeutic part, both, and we will have live discussion in between. And if you have any question, you can send it in our chat box, and we'll take up the question as and when the talk is over. So the first speaker is Dr. Mohan Ramchandani. He is an eminent endoscopist, and first he is going to talk about early detection and characteristic of colonic neoplasia, role of colonoscopy and advanced endoscopic procedures. Mohan, the stage is yours.
Thank you, Dr. Gupta, and I welcome you all. The colon cancer is rising, and it is one of the most common cancers globally. In fact, it is third most common cancer and the fourth most common cancer causing death. And if you see the dark blue color, that is the areas of high incidence. Fortunately, our country lies in a low incidence area, and it is the incidence is around 6 per 1 lakh. But if you see here, the important thing is that the colon cancer is though 4.4 per 1 lakh, but majority of people die. Out of 4.4, 3.4 die. That happens because our majority of cancers are diagnosed in late stage. And in late stage, the only option available for us is palliative therapies, and we may not be able to cure the problem. But we can cure the problem if we are diagnosing this disease early, especially when there are no symptoms. When the symptoms come, especially rectal bleeding, change in bowel habit, or rectal pressure, the local symptom that there is already a metastatic disease in 20%. While sometimes people may come to us with emergency admission, say for example acute obstruction, here also the prognosis remains worst. But if we say, for example, patient come to us for a colonoscopy and we find some lesion which can be easily treated, this is a very good scenario, and this is the early disease, and we can do organ preserving endoscopic surgery to remove that cancer. So the colonoscopy is the most accurate for colorectal cancer. It not only helps us in localizing, but also take biopsies. We also can detect any synchronous lesions or remove polyps. The other options which are available are like capsule endoscopy, which is now we have a capsule dedicated to colon, but unfortunately the sensitivity and specificity is much lower than the colonoscopy. So though it is non-invasive, but it's not up to the mark. We also have some other non-invasive methods like CT colonography for detection of these cancers, but still we have to do a lot of work to improve the sensitivity and specificity, especially to detect lesions which are less than 10 millimeter in diameter and which will be like precursor for cancer. So definitely we will depending mostly on colonoscopy, and in colonoscopy we can not only diagnose advanced cancers, which is, as I said, is not a favorable situation. We want patients to come to us in asymptomatic stage, and we can then diagnose these cancers in the form of polyps, sessile polyps, or other lesions which are very, very important for us to be, by seeing, we can say that these cancers are either invasive cancers or these are non-invasive cancer. In fact, we diagnose these cancers based on morphology only. Once we see a colonoscopic picture and we classify them into many types, especially the non-granular and granular variety. And non-granular, what we called is N for not good. That is, these are the cancers which are more submucosally invasive versus granular, G for granular and G for good, and that these granular cancers are not more submucosally invasive. In fact, we call them as benign, and these are pre-malignant, which can be easily resected. And based on this morphology, we say that these cancers are either invasive in the form of, say, for example, these are the granularity. You can see this cancers with the granules, and this is not very deep submucosally invasive. But as this cancers grows and there are development of nodules and known as 1S, the sessile polyps developing on this homogeneous granulars, the invasiveness increases to 10.5%. While non-granular, as I told, are not good, and from the beginning only they are associated with more submucosal invasion, and especially if there is a depressed lesions, they are furthermore invasive in the tune of 30%. But this is just the morphology. But we have now lot of image enhanced endoscopy available which can catch this angiogenesis. Now angiogenesis is the formation of new vessels, and this happens when there is a transition from a benign lesion to malignant lesion. So this new vessel generation can be picked up by endoscopy known as image enhanced endoscopy. In fact, this is just like histopathology being studied endoscopically. And as we can see, these colonic mucosa looks like a pentagon, and if we see in details, these colonic glands which are in the epithelium, they empty into the lumen by a crypt epithelium, and this all glands are surrounded by these vessels. These vessels are nothing but blood supply to the colonic mucosa which come by arteriole. Then there is a subepithelial arteriole and it goes back to the veins. What if we can detect the abnormality of these blood vessels endoscopically? And this is exactly what is done by image enhanced endoscopically, and we can catch these mucosal capillary network which are nicely arranged in honeycomb pattern around a mucosal gland, and as the cancer develops, this becomes dystrophic like this. For example, there is a development from a normal hexagonal cancer to tubular adenoma, and these new vessels are basically classified nicely by various classification. By seeing this capillary pattern, like when the capillaries are dilating becomes irregular, or there is loss of irregular capillaries, as this severity increases, the cancer from benign becomes more deeper and deeper invasive and ultimately develop into a invasive cancers which require surgery. The good thing about this endoscopy is that once you catch these cancers in very early stage, you can resect them endoscopically. And this is the most commonly used non-magnification narrowband imaging. This is known as narrowband imaging, where we can diagnose these cancers based on color, vessel and surface pattern of the polyp. Say for example, if the color of the polyp is same as that of background, it is a hyperplastic polyp and it is a non-cancerous polyp. While if the color of the polyp is darker than the background, it becomes adenomatous polyp. Similarly, you can see the color here, the color is almost same as that of background, and here you can see very dark. So by mere switching to narrowband imaging, you can decide whether it's a dangerous polyp or a non-dangerous polyp. Similarly, we also see the vessels. If the vessels are not visualized or they are small lacy pattern vessels, we can diagnose these cases as hyperplastic, and if these vessels become thick and they are surrounding the white structure, that becomes adenoma. We also see the surface pattern, and you can see these are the dark spots surrounded by white. This is a hyperplastic polyp. While if there polyps showing a oval, tubular or branch structures surrounded by these brown vessels, it becomes adenomatous polyps. Not only this, but also by seeing other patterns, we can say that this cancer is already deep submucosal invasive. So by seeing a polyp, we can decide whether the polyp can be left alone because it is hyperplastic, or endoscopically resected, or referred to surgeons if it is deep cancers. And this is how nice classification help us. But unfortunately, there are some drawbacks. In type 2, we are not able to diagnose whether deep cancer is there or superficial cancer is there. So we can help by seeing these cancer in more detailed way. Say for example, if there is a pedicle is there, even if there is a nice 3, you can resect them endoscopically because you have a pedicle. While if there is a depressed cancer is there, even nice 2 becomes more invasive. So with the various permutation and combination, we can diagnose these cancers and decide whether this is an early cancer treated by endoscopically or by surgery. We also have many other classifications like Janet classification. I will not go into the detail, but it is a magnification based classification and is better to have more differentiation between low grade intramucosal cancers versus high grade intramucosal cancers. I will not go into this detail of this video, but this nice Janet classification is very, very important and has helped us to diagnose these cancers in a very early stage. We also deal with some of the sessile serrated adenomas, which looks exactly like hyperplastic polyps, but none of the classification have taken care. But we know that the hyperplastic polyps lies on the left side, while the sessile serrated adenomas lies on the right side. And by seeing these polyp on the right side, like flat polyp, transparent polyps, polyps with a big pit or O pit what we call, or surface grooves, we can diagnose these hyperplastic polyp as sessile serrated adenomas, and these polyps are pre-malignant and can be dangerous, so we cannot leave them alone, we have to resect them. With this, we say that by seeing the vessel pattern and surface pattern based on this image enhanced endoscopic, we decide these patients whether they can be treated by endoscopic resection or they require surgical resection. We also are now utilizing artificial endoscopy to catch these polyps, but not only catch these polyps, but also characterizing them into non-neoplastic or neoplastic polyp, not only by chromoendoscopy but also by narrowband imaging. And here is an example where we use artificial intelligence, and as you can see, as soon as this type of cancerous polyps are seen, there is a yellow mark which says that there is a polyp and we need to address this polyp. And once you see this polyp by artificial intelligence, we characterize this polyp. We go more nearer to these polyps which are precancerous and do magnification. Say for example, and this is the narrowband imaging, and the computer itself will tell us whether it's a neoplastic or non-neoplastic. And you can see here 99% polyp is chance is that this polyp is neoplastic. We further can decide by doing chromoendoscopically and seeing this by endocytoscopy. This is known as endocytoscopy, where we are seeing this polyp by the 500 time magnification and in fact seeing the histology. By this type of method, if we use such type of artificial intelligence, it is much better than human endoscopist, and it enhances not only the detection but also our ability to characterize a lesion. So in conclusion, I will say that when colorectal cancer is found in early stage before it has spread, the 5-year survival rate is 90%. The colonoscopy is the method of choice for early detection. Screening is the process looking for cancers or precancers who have no symptoms. Though we have a low incidence country and we do not have a national guideline saying screening is required, but we have a massive population, and that's why the colorectal cancer burden is high, though our incidence is low. But on individualized basis, we can decide about screening. We have methods like image enhanced endoscopy or artificial intelligence to improve the method of detection and characterization. And these classification like Janet or NICE enables us to identify these cancers in a very early stage and treat them. And we have a next talk by a very expert endoscopist, Dr. Zahir, who will tell us how to proceed once you find these cancers and how can we resect them endoscopically, preserving the colon. That is the most important. If you present late, there is a surgical resection of the colon, while here organ preserve is done and cancer is removed right from the depth, and curative resection can be achieved. I thank you for your patient hearing, and I will go back to Dr. Gupta.
Thank you, Dr. Mohan, for your excellent talk. You have given an overview of various technologies, how to diagnose colonic neoplasia even without biopsy. So we have a couple of minutes. Yes, so we can take up a few questions, and to set the ball rolling, Mohan, what do you recommend in a community physician where colonoscopy is not available? How they pick up, when they should suspect that there is a evidence, there is a possibility of colonic neoplasia or colonic neoplasm. The second question is, should the community physician should take a biopsy whenever they find any lesion in the colon?
I think these are very pertinent questions, and I will say that if a community physicians, first of all, the question can be addressed like for a general population. I will say that for a general population, one has to be very, very vigilant about the symptoms of, do not take rectal bleeding as a pile bleeding or a hemorrhoidal bleeding. Always seek immediate attention, and the colonic screening has not been recommended, but that is the unfortunately only way where we can detect these cancers early. However, we can restrict in our community because of the economical issue. We may not recommend screening program, but we can also say identify high risk population, say for example family history of cancers or polyposis syndrome, where we can recommend to do screening, where we can pick up. For community physician, I think fecal occult test is one which we can recommend them, and when the fecal occult test is positive, they can be referred for colonoscopy. But if a colonoscopist is finding any lesions, I think if they are not able to characterize, at least biopsy should always be taken by them and referred to a specialized center.
Thank you, Dr. Mohan, for your excellent talk. Now we move on to the next topic, that is endoscopic treatment of early colonic malignancy. And to deliver this talk, we have an eminent endoscopist, Dr. Zahir, who is going to tell us how to do endoscopic management of these early lesions and which are the lesions which can be taken care of by endoscopist and when to refer for the surgical resection. Dr. Zahir.
My job today is to move further. Once you have diagnosed that this patient is having an early colonic malignancy, then how to detect it. So next few slides I will be talking about how to decide whether you need to resect this polyp or not, whether this polyp can be resected using the usual techniques or do you need any advanced techniques, and what are the special devices and accessories that you need for cutting this polyp, and some of the how to manage
प्रेजेंटेशन का आप तो कुछ देख ही नहीं रहे थे. You are not seeing.
these polyps may not be resectable endoscopically. Then this slide has already been depicted by Dr. Mohan, and you see that the polyps which are homogeneously granular, they have very little risk of submucosal invasion. On the other hand, if the same polyp develops a dominant nodule, which means that the chances of submucosal invasion are high. The reason why I am re-describing this slide is that the technique of endoscopic resection is dependent on the morphology of polyp, depending on these characteristics. And then you see this non-granular polyp, they have a little more risk of submucosal invasion. But if there is a pseudo depression, then the chances of submucosal invasion are very high. 1 in 3 of these pseudo depressed polyps, they have deep submucosal invasion. So this is very important that you know that how the morphology of the polyp impacts the technique that you use for resecting. So this has been described by Dr. Mohan, but again, then these are the 3 types of polyps, the top 3: hyperplastic low-grade dysplasia and high-grade dysplasia with superficial submucosal invasion. They are endoscopically resectable, whereas those with deep submucosal invasion, they are not endoscopically resectable. Now coming to the main aspect of my talk, that what type of endoscopic treatment is required. Now if you see the endoscopic armamentarium, you will see that there are multiple techniques which are available to resect these polyps. These include endoscopic mucosal resection, endoscopic submucosal resection, underwater EMR, cold snare polypectomies, full thickness resection, and then finally combined laparoendoscopic resection. So which technique to choose, it depends on patient related factors, the factors related to polyp, the expertise which is available to you, and the efficacy, complications and recurrence rates that have been described with these techniques. Now coming to the most simple technique and the most age-old technique that has been in use to resect these colorectal polyps. This includes the conventional EMR and more recently underwater EMR and cold EMR. So with what snare to use? So you have multiple types of snares available. You have to choose the snares wisely. So for example, on the right side of the colon, you have to choose a rotatable snare because you may have difficulty in positioning the snare. Especially on right side of colon, smaller snare should be used so that the risk of perforation is minimized. You can use braided and stiff snares for flat polyps because they help you in avoid slipping, and thin and monofilament snares, usually they are not used, but in those with where the lifting is not very good, these snares can be used. Now for cold snare polypectomy, dedicated snares are available, and for example, this is a captivator cold snare from Boston Scientific. This is a 10 millimeter snare dedicated for cold snare polypectomy. So these are the standard settings used depend on the type of electrocautery you are using, whether you are using an Olympus or Irby electrocautery. So coming to conventional EMR, the benefits of EMR over other resection techniques is that it's a quicker modality, it's cheaper, the learning curve is short, and en bloc resection can be achieved in almost half of the patients. The risk of complications is much less than as compared to endoscopic submucosal resection, and it is considered suitable for lesions which measure less than 25 millimeters. Although it can be used for larger lesions as well, but then it becomes a piecemeal EMR with higher rates of recurrences. Now, how do you, once you have resected this large polyps by EMR, then there is enough data to say that if the lesion is more than 25 millimeter or if the lesion is on the right side of the colon, you should prophylactically close this lesion to prevent delayed bleeding. So, which side polyps to be closed? Distal polyps, you should not clip prophylactically. Smaller polyps, less than 20 millimeter, you should not clip prophylactically. So the only benefit of prophylactic clipping is you do it for larger polyps and those on antithrombotics and towards the right side of the colon. So now we have this improved, enhanced knowledge regarding the bleeding patterns, the risk of bleeding, and therefore EMR is a much safer procedure now because of the recent advancements that we have done. The main problem that has been described with EMR is recurrence, and this is the Achilles heel of EMR. So overall, you can see recurrence in 15 to 20% cases, and the main reason is if you resect a larger polyp in a piecemeal fashion. So the rate of recurrence, if you do a piecemeal EMR is as high as 20%, and majority of the recurrences can be found in initial 6 months. So how to prevent recurrences? Now there are two main techniques, and these have been described by the father of polypectomy, I'll say, in the current era, Professor Michael Berg. And you can see the first technique is STSC, which is called as snare tip soft coagulation. Means once you have resected this polyp by EMR, you use the same polypectomy snare in soft coagulation mode and do a soft coagulation of the margins. So this has been shown to reduce the recurrences by more than 50%. The second is there are polyps which are not very good lifting. In these polyps, once you have resected, there is a portion which is left and which does not lift up no matter how much solution you use. So in this, the technique of cast has been described, which is also called as cold avulsion with snare tip coagulation. So with this technique, you can resect these fibrotic areas and achieve good results. Now we see that with conventional EMRs, we have several good techniques available where we can optimize the result of polypectomy. So coming to the underwater EMR, which has been the talk of the town, and especially this is helpful in polyps which are more than 20 to 25 millimeter, because the chance of en bloc resection greatly increase if you do an underwater EMR, which means that you don't need to inject any solution, you just fill the colon with water and resect this polyp. So the chances of en bloc resection are much higher with underwater EMR and complications similar as compared to conventional EMR. So when should you consider underwater EMR over conventional EMR? That if you get polyps more than 20 millimeter, which are flat, sessile, which have type 2A morphology or according to Paris classification, you can choose these polyps for underwater EMR with better results as compared to conventional EMR. Coming to cold snare polypectomy, now you've seen that conventional EMR traditionally uses a hot snare. In cold snare, we don't use any electrocautery, and the world is moving towards cold, and the main reason being that the delayed bleeding and delayed thermal injury are virtually eliminated if you use cold snare EMR. Now the basic technique of cold snare EMR or cold snare polypectomy is that you push down towards the mucosa when you are cutting these polyps, as opposed to the conventional EMR where you lift up the polyp. So here is an example. You can see that the technique of cold snare polypectomy, small diminutive polyps less than 6 millimeter, this technique is very good. And now there is sufficient data that even polyps up to 10 millimeter in size can be safely resected with this technique of cold snare polypectomy. This is safe, there are no major adverse events, and the patient can go back home on the same day. So this is one of the very well conducted randomized trial which did show that this technique is equal to the traditional polypectomy technique in polyps measuring less than 10 millimeter. It has also been used for larger serrated polyps, but the data are still limited. Now coming to the second main modality of polyp resection, which is endoscopic submucosal dissection. So when you choose ESD and why? ESD is a technically demanding procedure. So therefore, when you choose ESD, you often need to think that this patient may be required to shift to a higher center where expertise of endoscopic submucosal dissection is available. So for larger polyps, ESD can achieve en bloc resection in virtually all the polyps, especially the polyps where the risk of submucosal invasion is high. You choose ESD because you want the polyp to be resected in one piece, not multiple pieces. So it's very important, if as a primary care physician you are seeing a patient with polyp, and if the polyp is larger than 20 millimeters, you should always remember that this patient may get benefited with specialized dissection techniques like endoscopic submucosal dissection. So these are some of the indications where endoscopic submucosal dissection may score over endoscopic mucosal resection. So the knives and accessories, these are the typical accessories and electrosurgical devices that we use during endoscopic submucosal dissection, and these are the typical settings on electrocautery that we use for endoscopic submucosal dissection on left and right colons. Of note, if you see that the electrocautery settings are higher in rectum because of thicker walls and lower towards the right side of the colon because of thinner walls. So coming to the technique, so this is pocket ESD technique, and in the current era, this is the most popular technique to perform endoscopic submucosal resection in rectum as well as in stomach. So there are few steps. You do a mucosal incision, create a mucosal incision, and create a tunnel till the distal aspect, till the proximal aspect of the polyp, and finally you can see this is the video here. The first is you create a small mucosal incision. You don't create a circumferential incision in the first go, you just create a small incision, and then subsequently you create a pocket and go towards the proximal end of the polyp. Means you traverse the polyp through this tunnel, and finally what you do is you cover the right and left side. So you extend the mucosal incision, do lateral dissection once you have completed the tunnel. So here we have completed the tunnel, and now you are proceeding towards lateral dissection. So finally, once you do a lateral dissection, once on right side, once on left side, so this is we are completing the incision on the left side, and then finally the polyp can be resected. So very convenient technique. You don't require any special traction techniques, and the polyp can be resected and blocked very conveniently. Suppose if you are not using pocket ESD technique, so there are now new methods of achieving traction and easifying the procedure of your endoscopic submucosal dissection. So these are some new devices, new type of counter traction clip that's available in the market now, and it can be very conveniently used to achieve traction and make your procedure easy. So now over the years what we have learned is endoscopic submucosal dissection procedure is no doubt it's a challenging procedure, but there are ways where you can simplify the procedure details. Now coming to the conclusion of what we have seen so far, that what should be done in a case with polyp which has a lateral spreading polyp like this one. So if you see the top two columns where the chance of submucosal invasion is less, I can proceed with EMR because there is very little risk of submucosal invasion, whereas on the other lower two pictures, if you see, the chance of submucosal invasion are high. So I will prefer endoscopic submucosal dissection in these two cases. So it's very important that you classify these polyps, you ask for the help of an expert and decide which may be the best resection technique in this case. Of course, there are other factors like size of the lesion, age of the patient, comorbidities and expertise, because ultimately we want to send the patient alive. So what's beyond EMR and ESD, I'll just talk about for a couple of minutes more, because now this is an upcoming technique where you can resect the polyp in full thickness, and this is especially useful if somebody has attempted a polypectomy outside. It becomes extremely difficult to again resect that polyp with EMR or ESD. So suppose somebody has attempted this resection, you try for EMR, but if it's not possible, then this is the way to go. So this is using a full thickness resection device which is available from OVESCO. You can achieve full thickness and safe resection using this new modality. So now there is almost no case where success cannot be achieved because of the availability of new devices and new techniques. The final, as a final slide, I'll also like to acknowledge the role of surgeons when you are performing an endoscopic resection. So on some occasions, the polyp is at such a difficult location that no matter what you do, you cannot reach the polyp site satisfactorily in a good position. So in these cases, your surgeon can provide assistance to you and present the polyp to you so that you can resect the polyp either in full thickness or you can also do a partial full thickness resection. So in these cases, a cooperation with laparoscopic surgeon can really provide benefit to your patient. I have resected the lesion. What's next? So if you send the region for histopathology and you find any of these findings like deep submucosal invasion, lymphovascular invasion, poor differentiation, positive margins or tumor budding, you send the patient for surgery. Otherwise, you keep the patient under regular follow-up. So to conclude, now it's feasible, possible to diagnose polyps endoscopically and to finally manage them endoscopically. Majority of the polyps can be managed endoscopically. It's very crucial to characterize these polyps before you proceed to resect these polyps. And endoscopic resection is definitely a good option in majority of the polyps. There are multiple techniques and they are cooperative techniques, and they are complementary techniques, and they are not competitive techniques. And recent advances in EMR and ESD, I think we in the near future we are likely to resect these polyps with better efficacy and better safety. With this, I thank you all for patient listening.
Thank you, Dr. Jahir, for an excellent overview of the various techniques of managing endoscopic management of colonic neoplasia. So my question to you is, in your opinion, what should be the learning curve for a endoscopist for going ahead with these advanced techniques like ESD or other technologies what you have demonstrated?
So, if you talk of the resection techniques, there are multiple techniques, and each technique has its own learning curve. For example, EMR has a shorter learning curve, and 10 cases under supervision should be good enough before you start performing EMR. But it also depends on the complexity of resection, also depends on the location of the polyp, the ease of lifting, and other patient related factors. So it's very important that when you talk about the learning curve, it varies not only from endoscopist to endoscopist, but also according to the technique which is being considered for resection of that polyp. Coming to endoscopic submucosal resection, the learning curve is longer, and I believe that 50 cases under supervision are essential before you can proceed for resecting complex polyps with endoscopic submucosal resection. In contrast, some of the newer techniques like underwater EMR, the learning curve is likely to be very small because there is no extra skill required to lift the polyp, and full thickness resection also the learning curve is very small because no extra skill is required, and it's a purely a mechanical procedure and can be learned very quickly.
Thank you, Dr. Jahir. And now we have completed our diagnostic and of early colonic neoplasia and their endoscopic management. So sometimes now we have situations where the surgery continues to be a gold standard for management of colorectal neoplasia, but there are certain situations where the surgeons are not in a position to operate because of various reasons, because there is an obstruction, there is an emergency. So what is the role of endoscopies in these situations? What is the role of stenting in these situations? How does it help our surgical colleagues, or is it the final management for end stage colonic cancer? So to discuss this issue, we have our eminent endoscopist and colleague Dr. Sandeep Laktakia. He is going to talk about role of colonic stenting in advanced colorectal neoplasia. Sandeep, please.
Thank you, Dr. Rajesh, for the introduction. In this forum, I would like to highlight the role of colonic stenting in colorectal cancer. As Rajesh rightly mentioned, that the treatment for colon cancer is surgery and surgery. If surgery cannot be done for one reason or the other, and will a colonic stent placement help that patient, is what we're going to discuss in a situation of a colorectal cancer. So in this talk today, I will be covering upon the data on palliation of colonic stenting and data on the bridge to surgery for colonic stenting, and what do the guidelines mention about these. As Dr. Mohan mentioned in his talk in the beginning, colorectal cancer is a very common cause of malignancy in humans. It's the third most common malignancy, especially in the western part of the globe. Also, it is a very common cause of a cancer-related death worldwide. About 1/3 to 10% of the patients who have colorectal cancer, which may or may not have been diagnosed earlier, can present with a malignant colonic obstruction. And what does it mean? Any bowel obstruction is a surgical emergency, and if the surgery can be done, that's the best way to manage such situation. But if not, for a variety of reasons, when the patient is unfit for surgery or the critical situation of the patient, then we can have to opt for a non-surgical methods to palliate to build him up for surgery so that that can be a more curative option can be taken up later on. So malignant colonic obstruction is a GI emergency, just like obstruction in any part of the bowel, and requires an urgent decompression. If not done, this can lead to electrolyte and fluid imbalance, bacterial translocation from the colon to the systemic circulation, colonic necrosis, which itself can become a second emergency in the same patient, and even death. So all these 4 factors are critical and have to be corrected before to solve the problem of the patient. Surgery used to be the considered gold standard for colonic obstruction. However, surgery in emergency situation carries its high mortality and morbidity, and also a need for permanent colostomy. So if we can reduce these factors and have a better outcome by at least half or more than 50% improvement, then that should be the practice. There have been several studies on this front. Some of the early studies which came up almost more than 15 years ago were of the use when the stents came into picture, of use of these kind of stents, metallic stents, in different GI scenario. And so was the use in colonic obstruction. The earlier studies were not so favorable in favor of stents, and some of the studies had to be closed down because of the risk of complications, including perforations with colonic stenting. Subsequent studies have shown equivocal results and better results with improvement in the stent technology. So at that time there were no clinical advantages with stent, and there were concerns about increased number of perforations, especially the first study as we see in 2008. This study had to be abandoned because there were a higher risk of perforations in the stent arm. Before we go further, let me show you a video of how colonic stent is done. You can see a large tumor in the colon. This is in the sigmoid descending colon junction, which is blocking the lumen of the patient, and this patient presented acute obstruction, unfit for surgery from the anesthesia point of view, and hence we came into picture to place a stent. Under fluoroscopy, we pass a guide wire through the lumen, obstructed lumen, go proximal to it, inject some contrast to define the length of the stricture as we can see it here, after passing the guide wire deep inside. And once we are accurately positioned with a stiff guide wire inside, then we place through the channel metal stent, which are generally uncovered stents are preferred compared to covered stents, which we can discuss later on. And this is a stent which is going through the channel of a therapeutic scope. These stents, once positioned accurately, the aim is to place the center of the stent over center of the stricture, and then we deploy under fluoroscopic and partly in the endoscopic view. Under fluoroscopy, you see the center mark is right in the center, and as we pull down, take this to deploy the distal end or the lower end of the stent, and this is the final position as you can see it there. These stents are called SEMS or self-expandable metal stents, which reach the intended diameter over next 3 to 5 days, and hence open up the stricture and work only as a palliative method. I want to re-emphasize, colonic stent in colon cancer are only palliative and not curative. So let's understand what does it mean. Data on palliation and data on bridge to surgery. Data on palliation means that the disease is so advanced that even if surgery is attempted, it's unlikely to be curative. So can we place a metal stent in such a scenario and then avoid a surgery and then follow up with chemoradiotherapy if possible in such patients? So let me start with example of a few meta-analysis. This one is of 9 studies which came in surgical endoscopy in 2014 of comparing a stent arm versus surgery arm, and this was looking at the outcomes of surgery versus placement of a metal stent. There were 9 studies in this trial and had about 195 patients in the SEMS arm and 215 patients in the emergency surgery arm. The mortality, morbidity was not different between the two arms, and so was the 30-day morbidity, early morbidity. But late morbidity was higher in the SEMS arm and the hospital stay was lower in the SEMS arm. What does it mean? It means that if you place a stent in a patient who deserves a stent because of colonic obstruction, has a very advanced disease, is unfit for surgery, then it's better to place a stent for the simple reason that they have a shorter hospital stay. They also have less morbidity at 1 month period, but if this stent is kept longer, the morbidity is higher in the stent arm compared to a surgical arm, because surgery there it's more definitive and you can do a colostomy with or without removing the or debulking the tumor. Another more later study, which is of 13 studies, came from the Chinese group of 400 odd patients in SEMS and the surgery arm, and this was aiming to compare the palliative SEMS placement versus surgery in the outcomes. Once again, these are the 13 studies which have been included, and this also shows a little better trend towards the endoscopic or the metal stent arm. The mortality, early mortality was much smaller in the endoscopic arm, so was the short-term morbidity. But if you look at the longer morbidity, then the surgery scores, and so is the permanent relief on the clinical symptoms. The chance of stoma formation is much lesser, as we understand that these stents are patent and allowing the stool to come out from the natural passage, and hence requirement of surgery comes down since it's a palliative procedure. The requirement for ICU stay is much lesser, and so is the hospital stay time. So in net, placement of a colonic stent for palliation is better than a surgical, but this data is still debatable. There's no final word said on this front. If surgery can be considered, that should be the prime goal, but if not, then metal stents come very close second, but they have their advantages. Let's look only at the randomized controls trial, which consists of 4 studies of 125 patients each. And they sum up by saying that the need for permanent stoma is in a very small percentage of 14 versus 84% in the surgical arm, and the hospital stay requirement is much shorter in the SEMS arm versus those in the surgical arm. They are very intuitive results. The rest of the parameters remain equivocal on either side. So what is the summary of data on palliation of colonic SEMS in a patient with advanced colonic malignancy? The overall mortality and morbidity with SEMS are not superior, although the trends are towards that. Also, the data on effectiveness are contradictory, but metal stents in colon do have some specific advantages. For example, they reduce the total hospital stay, including the ICU stay, and reduce the need for stoma creation for palliation of the incurable colorectal cancer. Let's move forward on data on bridge to surgery. What does this mean? Our aim is always to cure these patients by removing the tumor by surgery. But if the patient is unfit and has come with an obstruction, all the anatomically or physiologically the tumor looks to be operable, can we place a stent to bridge the gap? Because if we do a surgery, then it becomes a 2-stage surgery where the first stage is to make a colostomy, and then few weeks to few months down the line, a definitive surgery is done. So if we can avoid the first step of surgery and then take them up for a definitive surgery, what does data speak on this front? So same, I would touch upon few, because of paucity time, on only the meta-analysis. This is a meta-analysis of 7 studies, almost about 200 patients in each arm, evaluating the efficacy and safety of either procedure. These are the number of patients and the trials which have been published, and most of them are high-grade trials. In this table, as you can see, the mortality is almost equal on either arm, but the morbidity, the green highlighted blocks, are in terms of favor, and they favor the metal stent arm. So the favorable angles are morbidity, the need of primary anastomosis rate, and the permanent stoma rate. These are the different factors. the primary stoma rate, anastomosis rate is higher with direct surgery, but after stent, this is a little higher, statistically different, but the need for permanent stoma is much smaller in patients who go under metal stents. Another meta-analysis on the same front to evaluate the efficacy of metal stents versus surgery. These are several studies included in this trial, and in the effect size, it shows that the morbidity comes down in the SEMS arm. The primary anastomosis rate is higher in the direct surgical arm, and the permanent stoma rate is much lesser by about 25% or 27% to be specific in the metal stent arm. To sum up the data on need of colonic SEMS as a bridge to surgery, that colorectal stenting is a safe as an emergency surgery with regard to mortality and appears to have a more favorable overall complication profile and decreases the chance of a permanent stoma rate. What do the guidelines say? There are two major societies which give guidelines on this, that is ESG and the American guidelines. And the recommendations from them, I'll read it out for you. Prophylactic colonic stent placement is not recommended and should be reserved for patients with clinical symptoms and imaging evidence of malignant large bowel obstruction without signs of perforation. So if there's only obstruction, then only a prophylactic colonic stent should be considered, and not in a patient who's not obstructed. Even those who are obstructed and fit enough for surgery should be taken for urgent surgery than a metal stent placement. Second, colonic SEMS should be placed as a bridge to elective surgery. It is not recommended as a standard treatment for the left-sided colonic obstruction, because the results in the left-sided colonic obstruction, malignant colonic obstruction, the results of surgery versus stent is as good. And if surgery can be done, you can probably end up doing a one-stage surgery and not a two-stage surgery. For patients who have potentially curable disease of the left side colon cancer, stent placement can only be considered as an alternative to emergency surgery in patients who have a high risk of post-operative mortality. That means they have high risk from anesthesia point of view or have increased age. And the last important point in this guidelines is that metal stents in colon is recommended as a preferred treatment for palliation of malignant colon obstruction, except in patients who are considered for the treatment with anti-angiogenic drugs, anti-chemotherapeutic agents, because once you place these stents, the tumor opens up and stent can migrate and or cause perforation. To sum it up, let us look at the clinical decision making in a patients who have advanced colonic cancer and have an obstruction. If the patient is fit enough, acute resection should be done. If the patient is frail or has high risk from anesthesia point of view then and has a stentable lesion, they should go for stenting. But if not, consider a decompressing stoma only and not a primary curative surgery. Regarding palliative stenting, that means those who have an advanced disease, a tailored approach should be used, also based on the life expectancy. If stents can be placed, you can place them, but mind you that some of these chemotherapeutic agents can cause harm if this tumor opens up and the stents can then migrate. Alternately, we can consider a decompressive stoma placement or a resection, even a non-curative resection can be considered. So the take-home message for colonic SEMS in patients who have colonic cancers, it's a preferred treatment in palliative setting. However, it should be used only with caution in patients who have a curative setting and can be used as a bridge for a definitive surgery in a one-stage process later on. Thank you very much for your kind attention.
Thank you, Dr. Sandeep, for your lucid talk. So, my question is regarding the challenges in colonic stenting, Dr. Sandeep. So, do you find it is different for right-sided colonic obstruction or left-sided colonic obstruction? So, do you see any challenge in right-sided or transverse colon obstruction lesion?
As a colonoscopist, we are used to do interventions in a clean colon. This is one situation where we cannot clean up the colon, or in maximum we can give enemas to clean the distal part of the bowel below the obstruction. And hence the stenting is much safer or easier technically in the left-sided disease. To the right side disease, the enema may or may not reach as far up to the right side of the colon, and hence most of the studies are limited to the left-sided disease, rectosigmoid or the left colon or sigmoid descending colon junction.
Thank you very much, and now we conclude this session. I hope you enjoyed this session. And at the last but not least, I would like to thank our chairman, Dr. Nageshwar Reddy, and director and co-chairman of the institute, Dr. G.V. Rao, for giving this opportunity to participate in this important session. Thank you very much for participating in this session.